Assalamu alaikum. Good evening, everyone, and welcome to today's webinar, Medication Without Harm, organized by the Saudi Patient Safety Center in collaboration with WHO EMRO. So first, let me introduce myself. I'm Ala Al-Umari, a patient safety specialist, and I will be responsible for hosting this session. Today's session will last for 90 minutes. And before we get started, I'd like to go over a few tips so you know how to participate in today's event. You will have the opportunity to submit a text questions to our presenter by typing your question into the question pane in the control panel. You may send your question at any time during the presentation. We will collect this question and address them at the end of the session. And now I would like to introduce our speaker for today, Dr. Dalia Alghamdi. She is a quality consultant at Ministry of Defense Health Services, Continuous Quality Improvement and Patient Safety Department. She received her Bachelor of Pharmaceutical Science from King Saud University in Riyadh, and then she graduated in 2011 with a Master of Science in Healthcare Policy and Management from the University of Birmingham, the United Kingdom Health Service Management Center, and she is a fellow of the Institute of Safe Medication Practice. And now here's our speaker, Dr. Dalia, if you please.
Thank you, Ala, for this introduction. How is my voice? The volume is okay?
Yes, it's okay.
Yeah, okay. So our webinar today will cover medication without harm. And by the end of this, our learning objective will be, the participant will be able to know the definition of polypharmacy, to understand the risk factor of polypharmacy, and understand the importance of medication reconciliation and its implementation strategies, to recognize the physician, pharmacist, all healthcare providers' role in medication reconciliation. Both patient and healthcare providers has a role to play in order to ensure medication safety. Initiating with the third WHO Global Patient Safety Challenge, Medication Without Harm, developed, and WHO also developed a campaign to increase public awareness of the safety issues related to medication use. WHO aimed to develop strategies for safer medication practices to reduce risk of polypharmacy and transition of care, where we will understand it through understanding the medication reconciliation process and implementing certain bundles and interventions in order to assure medication safety and patient safety in our organizations and facilities. So first part, we will cover the polypharmacy, and we will understand it with a definition, giving examples, and how we overcome the issues with the polypharmacy. So it's a routine use of 4 or more over-the-counter prescribing or or prescribing or traditional medication at the same time by a patient. Common in older adults because they might have more than one chronic disease. They might need more than one medication, 4 or 5 medications. And polypharmacy increases the risk of the following: side effects, drug interactions. As the number of medication increase, we are expecting to have more drug interactions. Reduce the adherence of the patient. Having more medication will decrease the adherence to take the medication within appropriate time, maybe, or arrange it with the meal. Is it before meal or after meal? So it might affect all these by polypharmacy. So the risk factors for polypharmacy is either patient-related or healthcare system-related. So if it's patient, as we mentioned, it's in elderly, more than 60 years old patients, having a cognitive impairment, developmental disability, patient being weak or frail, lack of a primary care physician to follow up with the patient, his case, mental health conditions, they might not be able to focus or concentrate on how to take their medication as a result of their mental health condition, multiple chronic conditions, residing a long-term care facility, seeing multiple subspecialists. So visiting more than one hospital or facility might also lead to having a polypharmacy. So healthcare system, it's poor medical record keeping, poor transitions of care, prescribing to meet disease-specific quality metrics, use of automated refill system where nobody can communicate with the patient in order to understand what's the current list of the patient medication. So before starting any new medication, we need to ask, are there any underlying causes that should be addressed first? Is the new medication treatment is necessary? For us as a healthcare provider, we need to ask ourselves these questions. Are there non-pharmacological options? Are there preventive measures that can be tried first? Such as doing exercise, control your diet before starting certain medication. Are there benefits? Are there proven outcomes? When will the benefit be seen? So also we need to look at the period of time for how long this medication will be used, because it's maybe if it's prolonged use, it might affect our patient negatively. What are the risks? What are the patient caregiver goals of therapy? What are my goals of therapy? What is the patient estimated life expectancy when considering age and comorbidities? So weighing risk with benefit at the time we are starting any new medication. Is the patient adherent to currently prescribed medication? So when starting any new medication, consider it as trial rather than permanent addition. So we might say, let us start this medication for a certain period, and if it's not effective, we will discontinue it and start other medication. Follow up with the patient in a timely manner. Don't start the patient in a certain medication and forget about him, or not following up, or not assuring this information with the patient that he needs to make the follow-up. Assess for the effectiveness and safety at follow-up visits. When renewing refills, consider the benefit versus the risk of continuation, long-term or short-term use of medication. So we need to interview patient or caregiver, review records, gather full medication lists before starting any new medication. We need to assess all medication for indication of use, match medical, surgical, and social history. So when we check and assess all medication for the indication of use, because there might be a duplication in the medication, such as writing pantoprazole with omeprazole, which is used for the same indication, as an example. A benefit versus risk, time and magnitude of effect, adverse drug events, interactions, allergy, other consideration such as time, and a treatment cost, goal of therapy, In addition to that, we might look at the plan, discontinuation, continue same treatment, starting a new treatment if this treatment is not beneficial benefit for the patient. So this will drive us to the second part of this presentation, which is the medication reconciliation and transition of care. And we need to ask ourselves three questions: what, why, when? This all open-ended question in order to understand why we need to use this process. So what is transition of care? So transition of care occur when a patient moves between facilities, sectors, and staff members, increase the possibility of communication errors, which can lead to serious medication errors. And we are seeing this on daily basis in the hospital and other healthcare organizations. So what is medication reconciliation? It's defined by the IHI, Institute for Healthcare Improvement, as the process of identifying the most accurate list of all medication a patient is taking, including name, dosage, frequency, and route of, and using the list to provide correct medication for patient anywhere within the healthcare system. So that's the definition of by IHI. And why is medication reconciliation important? Most frequently occurring type of medical error where, without having a good medication reconciliation in place is the medication errors. And you know that we have a categorization by the NCCMERB for medication errors, starting from not harming a patient up to leading to harming the patient and sentinel events. And because of that, we need to focus in this process. Most frequently cited category of root causes for serious adverse events, ineffective communication. As a healthcare provider, we need to communicate with each other, and we need to communicate with our patient and caregivers in order to understand what is the current situation for our patient. Most vulnerable part of a process link between the step, the handovers. Each healthcare provider should give the right and good information, complete information about the patient at the time of handover. So the initiatives and the intervention and where we can look at as a reference, as international level references for us as a healthcare provider when we start to focus on medication reconciliation. The High Five Project, High Five Guiding Principles, Medication Without Harm, WHO, the Saudi Center for Patient Safety, and the Joint Commission International, American Society of Healthcare Health System Pharmacists, ASHP, Institute for Safe Medication Practice in Canada. All these references available within our hand in order to improve or implement the medication reconciliation activity. How do we justify the need for a medication process that addresses transition of care? Medication error in 6-month period decreased by 70% after implementation of the medication reconciliation process at all phases of hospitalization. Other references showing us that they found 94% of patients had orders changed after ICU stay by recounseling all pre-hospital ICU and discharge medication order. Nearly all medication error in discharge prescribing were avoided. And this is a brilliant result. So all of us need this practice in our hospitals in order to have no medication error at admission or discharge and transition of care. So SIBAHI, the Saudi Central Board for Accreditation for of healthcare institutions, reflecting also and requesting us to implement the process of medication reconciliation. And this mentioned in Medication Management Standard 20 and 20.3, where safe prescribing, ordering, and transcribing of medication orders are guided by a clear policy and procedure. And medication reconciliation is conducted at the time of admission and discharge. In addition to that, the international body, which is the Joint Commission, have a requirement at admission and requirements at discharge. And we will go through them in this slide. Medication management and use number 4, prescribing, ordering, transcribing are guided by policies and procedure. And the measurable element which cover this, that the patient record contain a list of current medication taken prior to admission, and this information is made available to the pharmacy and the patient care providers. The second measurable element, initial medication orders are compared to the list of medication taken prior to admission according to the organization established process. In regarding to the requirements at discharge, ACC 4.3, the complete discharge summary is prepared for all patients, and the measurable element covering this, the discharge summary contains significant medication, including discharge medications. A patient education and follow-up instructions are given in a form and language the patient can understand. Okay, and you can see this in the Institute for Safe Medication Practices, that they have a patient education material in English and Spanish language, and you can translate it to any other language as you. Follow-up instructions are provided in writing and in a form and language the patient can understand. So, required step in the reconciliation process, develop accurate lists of patient medication at the time of admission. Reconcile listed medications with the new orders. And we have to look at the omission, duplication, addition, and adjustment. Update list as order change during episode of care. Communicate updated list to the next provider and patient as required. Identifying and resolving discrepancies. Discrepancies found between admission medication orders and the best possible medication history can be divided into 3 main categories, either intentional or undocumented, intentional or unintentional. And we will understand each one. The intentional, the prescriber has made an intentional choice to add a change, discontinue a medication based on the patient plan of care, and their choice is clearly documented. Okay, undocumented intentional, the prescriber has made an intentional choice to add, change, discontinue a medication, but this choice is not clearly documented, which needs clarification by other healthcare providers. Unintentional, which we will understand it in this slide, the prescriber unintentionally changed, add, or omitted medication. The patient was taken prior to admission. And the unintentional discrepancies fall into 2 main categories, either omission or commission. In order to understand what's the difference between the omission and the commission, patient was not ordered a pre-admission medication. There is no clinical explanation or documentation for the omission. Commission, incorrect addition of a medication not part of the patient's pre-admission medication, and there's no clinical explanation or documentation for adding the medication to the patient's therapy. So it's either removal or adding a medication to the patient medication list. So when you start implementing the process of medication reconciliation, healthcare providers would start asking themselves, whose job is it? Is it pharmacist? Is it physician? Or is it nursing responsibility? Everyone is responsible for ensuring that medication are used safely. Each profession has its own unique skills and knowledge. Good collaboration between various members of the healthcare team bring together those skills to improve the quality and safety of patient care. And really, if you start implementing the medication reconciliation within your organization, you will start understand that each healthcare provider, from his background, from his profession, having different ideas that could be added all together in order to improve the process of medication reconciliation. So taking a best possible medication history, the goal of that, in order of taking the best possible medication history, is to obtain complete information on the patient pre-admission medication regimen, including names, formulation, dosage route, frequency indication, allergies, and time of last dose, which mean that the patient is adhering to his medication. Try to use at least 2 sources of information when possible and explore discrepancies between them. Patient givers, we might ask the patient to bring the pill bottles or medication list that he have or she had in at their home. And it's better and good that you have this list as soon as possible within the first 24 hours of the hospitalization. If starting point is a medication list, review and verify each medication with the patient. Assume all lists are inaccurate. So we need to understand that if we have a medication list, we need to review it and verify it, okay, with the patient. If starting from scratch, consider the following prompts. What medication do you take at home? What medication do you take every day, regardless of how you feel? Which medication do you take only sometimes? Fill in the gaps: dose, frequency, formulation, route of administration. All this information, asking open-ended question to the patient, will add to more information. Even the herbs, any patches, any over-the-counter medication, you need to ask open-ended question in order to let the patient give you more information. So here are the top 10 information that we need to take it from the patient by ISMP Canada, and this reference is available. And then multidisciplinary approach: admission, transfer, or discharge. And this is admitting physician responsible for documenting and comparing home medication list and deciding what medicines to continue. Nurse and pharmacist review list. Transfer: physicians on transferring and accepting teams review medication dosage and when it's administered. At discharge, physician and pharmacist compare outpatient list and inpatient list to review medicine instruction with the patient. Shared vision, and sometimes we say it's in order to have a complete picture, you have to add the view of the patient. So patient and healthcare professionals will rely on pharmacists to provide leadership in designing and managing optimal patient-centered medication reconciliation system. Why? Why pharmacist is the most important and unique profession in order to having this knowledge. The way the pharmacists trained, studied, they have distinct knowledge, skills, and position in the medication use process. They can facilitate and implement effective medication reconciliation tools for patient and interdisciplinary use. Pharmacists will lead change in achieving safer and more effective medication use by educating the patient and healthcare professionals regarding the benefit and limitation of the medication reconciliation process. Imagine if you have a good medication safety officer, having a good team in a medication safety team, they will be able to lead the implementation of medication reconciliation in the hospitals. Pharmacists are frequently integral to the medication reconciliation process. They might not be the best solution. Pharmacists often have other essential tasks to carry out, often best to target high-risk patients who go most at risk of an adverse drug event during transition of care. So research suggests the following are high risk: older age, 55 to 80 years, polypharmacy, 4 to 13 medication, more than 3 comorbid conditions. Okay, other information to be, we need to be aware about it. The medication side effect, special instruction for taking each medication, special food or times should be at night, for example, such as atorvastatin or simvastatin, for example, or special food instruction before food or after food with 2 hours or 1 hour to separate the 2 medications from each other. Activity which might affect the benefit of the medication, which medication might be discontinued when a new medication is added, medication with names that sound just like or look alike. So look alike, sound alike medication. So implementing medication reconciliation strategies. In order to implement the strategies for reconciliation, refer to the arrival list when writing medication order for admission, transfer, and discharge. We need to compare the arrival list with every medication ordered at admission or discharge and look for discrepancies. Address all discrepancies with the physician, and this happens through communication of the healthcare provider at the time of admission or discharge. Reconciliation in 3 steps: verification, collection of medication history, clarification, ensuring that the medication and doses are appropriate, documentation, change to orders or reason for differences. Approach to medication reconciliation: performing robust, thorough, and accurate medication reconciliation during transitions in care involves interprofessional collaboration among pharmacists, nurses, and physicians, and don't focus in having two healthcare providers, two groups, such as pharmacists and nurses. No, it's a collaboration between the three healthcare providers, pharmacists, nurses, and physicians, because each one have their own skills and knowledge in order to improve the implementation of medication reconciliation. Integrating medication reconciliation into discharge summary, combining reconciliation with medication counseling with patients. JCI summary of safe practice. A recommendation for counseling medication at admission. Collect complete and accurate pre-admission medication lists. Collect complete lists of current medication, including dose and frequency for each patient on admission. Validate the pre-admission medication list with the patient whenever possible. Assign primary responsibility for collecting the pre-admission list to someone with sufficient expertise within a context of shared accountability. The ordering prescriber, nurse, pharmacist must work together to achieve the accuracy. Write accurate admission order. Use the pre-admission medication list when writing orders. Place the reconciling form in a consistent, highly visible location within the patient chart, easily accessible by clinician. Writing orders. Reconcile all variances. Assign responsibility for identifying and reconciling variance between the pre-admission and admission medication list and the new order to someone with sufficient expertise. Reconcile the patient medication within the specified time frame. Okay, time frame. So, for example, if we want to make the reconcile patient medication at the time of admission, that means less than 24 hours, which is acceptable time. Provide continuing support and maintenance. Adopt standardized form to use for collecting the pre-admission medication list and reconciling the variances. Includes both electronic and paper-based forms. Develop clear policies and procedure for each step in the recounseling process. Provide access to drug information and pharmacist advice at each step in the recounseling process, because this will help in improve the medication reconciliation. Implementing WHO high 5S for medication reconciliation. The first step to determine what needs to be done, who should be involved, and what are their roles and responsibilities, in order to make clear roadmap for us at the time of implementation. Yes, we need to know pharmacist role, physician role, nurse's role. What is the timeline for implementation? What are the major milestones and deliverables along the road to full implementation? Should a pilot test be done? And I advise on that we need to have a pilot study in certain areas, certain hospitals, if you are working in more than one hospital as a collaborative. How is a full, successful, and sustainable implementation is achieved? So when we look at the key steps to start, we need to secure senior leadership commitment. Without leadership commitment, you cannot move within your organization. So we need to assure that. We need to form a team who will be responsible at the beginning. We need to develop a work plan showing the responsibilities. Process map current and planned process. Define the problem. Set aims, goals, and objectives. Collect baseline data. submit baseline data, start small and build expertise in recounseling medication, because as I mentioned earlier, not everyone is expert or knowledgeable about the importance of medication reconciliation. You have to buy in the healthcare provider with you in order to support the ideas of implementation. Evaluate improvement being made, collect and monitor data, spread throughout the organization. So, training and competency program for student and healthcare professionals. Making it happen, design a process for developing the list, making it available, using it, updating it, and providing to the patient and next provider and physician. Develop the tools, develop the policies and procedure, train the staff, monitor the process, look for opportunities for improving the process. And if you are implementing this activity in more than one hospital, each hospital can learn from other hospitals who succeeded in implementing medication reconciliation. No need to reinvent the wheels in order to understand an issue or find a solution if the solution is available in one of other hospitals. Or you can use the references that we mentioned earlier in the presentation. So when we look at knowledge, skills, abilities, and this showing the competency and development, knowledge, skills, abilities, understanding of medication reconciliation procedure, ability to conduct patient medication history interview, ability to use all available resources together, medication history information, ability to identify medication discrepancies, ability to document in the record, ability to troubleshoot discrepancies identifies. Prerequisites necessary, that's the necessary background, knowledge, skills, abilities required of the staff prior to participation, knowledge and understanding of patient interview technique, asking open-ended questions, try to gather more and a lot of information from the patient without missing any important data that we needed in the medication reconciliation. Foundational understanding of required components for a complete and accurate medication history. So competency development, training and education that will be needed, didactic and experiential, that mean independent review of a guidance document regarding the medication reconciliation procedure, preceptors available for questions, experiential, observe pharmacist, complete one medication reconciliation, perform medication reconciliation assessment with the preceptor. Observation, how competency will be assessed, measured. Observation demonstrate proper method of obtaining, just a second. Observation demonstrate proper method of obtaining a complete medication list utilizing all appropriate resources, demonstrate knowledge of how to conduct medication history interview, demonstrate knowledge of how to identify medication discrepancies, demonstrate knowledge of how to identify, to communicate and identify discrepancies, method of assessment, direct observation pharmacist completing medication reconciliation, performance threshold successfully complete more than or equal to 90% of medication reconciliation competency checklist. Challenges and lesson learned from what we talk about. In the challenges in medication reconciliation, often no clear owner of this process. Time constraints might be a problematic area. Difficult to identify accurate sources of information. Poor healthy literacy. Patients do not know or cannot tell us what they are taking. Patients not admit what they have been taking. They sometimes refuse to tell the full story. Labels on bottles are often outdated or incorrect. Patients may take medication differently than prescribed, maybe because of lack of knowledge and understanding of how to take the medication. Medication lists are often inaccurate. Patients forgot several types of medication that are not taken daily, refrigerator, and medication that are not taken by mouth. Sources of confusion for patients regarding medication. Sometimes having a multiple name for a single drug. Some people might use the brand name or trade name, and the other will use the generic name. Failing to instruct patient about medication taken at home that weren't written for discharge. Switches to formulary versions when admitted. Changing the dosage strength or frequency without sufficient understanding by the patient as to why. Stress of transitioning through the healthcare system, language barriers, cultural beliefs, relationships with the healthcare clinician who is obtaining the history, interviewer skills level in the way of asking open-ended questions, understanding the literacy level of the patient, able to gather more information. So health information technology has been loaded as a solution for challenges in medication reconciliation. A consensus statement issued by the Society of Hospital Medicine highlighted the power of the health IT. The statement by SHM recommended an integrated and transferable personal health record. This record must be compatible across all settings. A note of caution, hospital-based medication reconciliation at care transition frequently identified unintended discrepancy, but many have no clinical significance. Bundling medication reconciliation with other interventions aimed at improving care coordination at the hospital discharge holds more promise. So how can we bundle medication reconciliation with other intervention? Medication reconciliation can be bundled with other interventions, individualized counseling of patients, coordination of follow-up appointment, post-discharge telephone calls, involvement of a care coordinator or nurse discharge advocate. Best practice in medication reconciliation, patient education. Patients should participate in the medication reconciliation process. And as you know, nothing about me without me. So they have to have their own voice in this practice. Encourage patients to keep an up-to-date list of medication and understand why they take each medication. During the discharge process, medical staff should ensure that patients are educated about any changes in medication regimen. Medication reconciliation helps patients recognize they are responsible for their own health care and what happens to them. So, lessons learned, medication reconciliation issues is not going away. The admission process is complex. The discharge process is twice as complex. No one likes to be asked the same question twice, including patients. No list is perfect. There is no quick fix. That means it will take time. And we can see that in the time of changing culture. If you want to change the culture, it will take time for you. So don't expect that you will implement medication reconciliation within 1 or 5 months. No, it will take time. We need to communicate and communicate and communicate, and this is the best way in order to understand each other and assure what's the meaning of some missing information. Be flexible, listen to the concern of staff. Multidisciplinary support is essential. To be successful, absolutely must demonstrate the value. This is not just filling out other piece of paper. Filling the forms of medication reconciliation is not enough. You need to work hard in order to let everybody understand and be on the same page of understanding. And these are the references that you can utilize at the time of implementing medication reconciliation. And by that, the presentation finish, and it's time, Ala.
شكرا دكتورة داليا، الله يعطيك العافية.
الله يعافيك.
Okay, we have 3 poll questions. We want you to participate in answering them. See if you have any more question after this poll question. So the first question is, polypharmacy increase the risk of A, side effect, B, drug interaction, C, reduce adherence, D, all of the above, E, A, and B. You still can participate in the question if you didn't answer yet. Okay, Dr. Dalia, first question. 7% of the audience give answer A. Then, just let me order it like this. Almost 55% answer D, all of the above. Then yes. After this, 25% of the audience answer E, A and B. So if you can explain more to the audience.
Yeah, actually, yes, D is the correct answer. As the polypharmacy increase the risk of side effects, drug interactions. As you have more than one medication, it might lead to drug interaction or drug-food interaction, and reduce adherence for the patient in order to understand at what time when he should or she should take their medication. So yes, this is the correct answer.
Okay, so the second poll question, undocumented intentionally is the prescriber has made an intentional choice to add, change, or discontinue medication, but this choice not clearly documented, which need clarification, or B, the prescriber has made an intentional choice to add, change, or discontinue a medication based on the patient plan of care, and their choice is clearly documented. So please choose your answer. Okay, for those who didn't get the question, this is the definition of undocumented intentional undocumented intentional. So which one is the right definition? The A choice or B choice? Is it clear or I have to explain more?
Yeah, as Ala mentioned, undocumented intentional is the definition of this either A or B.
Okay, Doctor, as you see, 80% of the audience choose answer A.
Yeah. So for me as a healthcare provider or prescriber, I can intentionally remove or omit or remove the list of medication should be changed. Sometime intentionally, I mean it. And if I mean it and document it, that will give an idea for the other healthcare provider who will see the form of the medication reconciliation or who will review after me that I have documented what I meant by removing this medication. However, there's unintentional but not documented. I think there's a duplication medication, so I removed one and I left one. However, I did not document it. And working as a healthcare provider, as you know, there is a transfer of care, there is admission, there is discharge, there is pharmacist, there is nurse, there is a physician. You need to document everything, all the medication and each step of the medication use process, you have to document it. Nothing should be done without documentation. And I hope this is very clear because it's very important in the medication reconciliation process. تفضلي ألا.
That's fine. The third question is implementation of medication reconciliation requested by A, GCI standard, B, SBAHI standard, C, both, A and B, D, none of the above. So feel free to answer, and we encourage all of you to participate in answering the questions. You are still waiting for your answers. Okay, Doctor, 85 of the audience choose both A and B.
Yes, actually, yeah, that's the correct answer because as you know, most of Saudi or healthcare organization within our country is looking for the accreditation of the Joint Commission International accreditation, and as a national body for Saudi Arabia, we are using SBAHI standards. And both national and international accreditation bodies are mentioning and talk and put special standard for medication reconciliation implementation within the healthcare organization. So this reflects and shows how important is the medication reconciliation in the in our healthcare system, and we need to assure that is happening. And please, I hope that if you do not initiate anything or have no steps done yet within medication reconciliation within your hospital, take this as a home message and start working in implementing medication reconciliation, as you will save your patient from harm and all the risk factors that we mentioned during the presentation.
Okay, thank you, Dr. Dalia. We're going now to answer the question submitted by our audience. And as a reminder, you still can submit your question through the Q&A panel in the attendees control panel. So, Dr. Dalia, we have 4 questions. The first one from Dr. Zayed, he asked if the reconciliation strategy has been adopted in the GCC countries, and if yes, to how extent we have done that.
Yeah, actually, I'm aware that certain hospital we've done a collaborative work in medication reconciliation. It was a collaborative between 18 hospitals in Saudi Arabia, and we just ended up this work, and it was successfully implemented. And in addition to that, if we are talking about Saudi Arabia, we are almost there, inshallah. Yani everybody should be implementing, because you will not be able to be accredited by the national body, which is Sibahi. And if you are looking for JCI, you have to do it. I think the same talk will be in other countries, such as United Arab Emirates or Kuwait or Qatar. I think they have started work. However, I'm not sure about giving an example if they have what they have done. It's a collaborative, or it's only single hospital have done this work solo. I'm not sure about that. I might look if you want to communicate with me later on, and we can find more and further information.
Okay, thank you, Doctor. Also, Dr. Zaid has another question. He asked if who should be doing the overall supervision of medication reconciliation in a hospital practice? Is it the quality department or any other departments?
Actually, a pharmacy department should make the initiative in implementing the medication reconciliation, and the big part of support will be from the pharmacy department. However, if you have a multidisciplinary team within your organization or facility, you should have a representative from the quality department. You need to have a representative from physicians, nursing, and you need to have the leadership support from the director of the hospital, the quality director. You have to be in the same page at the time of thinking and putting the plan of medication reconciliation. And to tell you the truth, in some hospital, there is a focus in the pharmacy staff only about the medication reconciliation. No, it doesn't work this way. It needs to involve everybody, everyone, and the quality representative could be part, because they might have data. They want to compare their baseline with their the end stage that they are done with implementation of interventions for medication reconciliation, and in order to measure the discrepancies or to measure the percentage of intentional or unintentional, the discrepancies in admission or discharge. So I think, yeah, there should be a quality representative.
Okay. Doctor, also we have a question from Dr. Ilham. She asked, can we do the failure mode and effective analysis before implementing the medication reconciliation process?
Sorry, can you repeat the question?
Can we do the failure mode effective analysis before implementing reconciliation process?
You might identify, for example, the number of medication errors, number of other risk factors with as a baseline for you before implementing medication reconciliation, as I mentioned, and then look at the number after implementation. Failure mode effect analysis, it's about adding something new or process within your organization, and you want to make sure that you are not making any failure within the process. About medication reconciliation, from my point of view, it's related to the medication error numbers. And yeah, you can do it this way.
Okay. Thank you, Doctor. And we have a question from Dr. Evelyn. Does the medication reconciliation can be implemented to the outpatient care for the first timer patient, especially specifically until the end of their care, or just exclusive for the inpatient upon admission or discharge?
Actually, you can implement it outpatient, but from my experience, we've been working on it only in inpatient hospital services. But again, you can make your forms and your policy and procedure at the time of coming visiting the clinic, because again, you need to take the best possible medication history from the patient. And sometime as an outpatient clinic, you or a doctor, you need to know what was the patient on. Maybe he is coming and his complaint is from the list of medication that he is using. You need to go back to his history. You need to communicate with him. You need to ask him open-ended question. But to be honest with you, we've implemented my experience, we've implemented in the hospital in certain areas within the hospital.
Okay, thank you, Dr. Dalia, again for answering the question and for the creative presentation. It was a pleasure to have you with us. So this concludes today's webinar, Medication Without Harm, on behalf of Saudi Patient Safety Center, WHO MRO, and our presenter. Thank you for joining us today. And we hope you have learned and enjoyed this presentation. Have a great rest of your day.
Thanks a lot, Ella.